We've presented a trial which is a randomised trial looking at a new type of therapy called a nanobody. This is a very important molecule which can act specifically and be manipulated to prevent the platelet VWF binding. It was a randomised trial where patients received standard therapy and they either received drug or placebo before plasma exchange was started, and this was continued following plasma exchange on a daily basis for up to 30 days after achieving remission. And remission is defined by normalisation of the platelet count.
What we achieved actually was the number of the days for the normalization of the platelet was significantly lower for those patients that they were treated with Caplacizumab. And as a secondary outcome was extremely interesting that because we could see that for 30 days that patients were treated with Caplacizumab, they were protected to have exacerbation. There was few mucosal type of bleeding, but in none of the patients there was a need to use the concentrate to solve the problem of the bleeding. So I would say all over, the drug could increase minimally the mucosal type of bleeding, but not significant bleeding episode that could create a clinical alteration for the patient to prevent the use of this drug.
The importance of this paper is twofold. Firstly, it's the method of action of the compound, which is really quite unique. It's not associated with significant side effects. It doesn't appear to be immunogenic. The second important, and probably the most important reason for this trial is that we have always been stuck in the acute scenario of trying to achieve a rapid increase in the platelet count, which in itself is associated with a better outcome for patients, and that's exactly what's been demonstrated in this paper.
I think it could have two significant impacts. One is sort of decreasing the dependence on plasma exchange. Despite the advances in immune suppressive therapy, better plasma exchange, better supportive care, the 10 to 15% acute mortality in acquired TTP in an acute episode has not been impacted. And I think this has the potential to do that.
For me, the most important thing was, even if I'm working and I'm trying with the PECs to remove the platelet, I'm trying to do the best that I can do at the immune system with the immunosuppressive treatment, but the disease is too fast and I'm not able to achieve the result I want. With this drug, I can control the symptom. I can detach the platelet from ultra-large von Willebrand factor and not having the consequence damage of this microthrombosis and giving me time to move on with the other type of the facility I have. That is fantastic. I mean, this is, I think, the reason why this paper is very much appreciated for the physician and also mainly for the patient, I would say.